All right, good afternoon, everybody. We're here with Dr. James Muller. We'll give this just a couple of minutes. We see the participant list skyrocketing here, but we'll give this about we'll give it a good minute here. I was just chuckling with Dr. Muller about the photo in his background. Hopefully we can get to that during today's webinar. We are recording this webinar, so Jim, no profanity this afternoon.
Yes.
But I'm super excited to have you on. I've known you now. I was doing the math. I met you in July of 2011. So going on 13, 14 years now. And I was thinking last night about this webinar and really truly how many people you've helped, not just in your career as a cardiologist, but as an advocate for global peace, and when you won your Nobel Peace Prize, and obviously you're very involved in the church, and have always been a guy I admired for your passion and your commitment to causes. But just I can't even fathom the amount of people that you've helped and the field that you've moved forward that we're going to talk about today. But grateful to have you on. For everybody that's joining us now, again, we're going to be recording this. We will have question and answer at the end, although if there are some questions that pop up throughout that maybe are mixed in, sometimes we do that, but honored to have you join this webinar, Heart Attack Risks Unveiled, with our guest, Dr. James Muller, who mentioned in some of the advertisements we put out there, former professor at Harvard Medical School, was a physician at Beth Israel Deaconess, most recently a cardiologist at Brigham and Women's Hospital. But that only begins to scratch the surface. Introduced the term vulnerable plaque, which we'll dissect here and unpack for the audience in great length over the course of the next 45 minutes or so. But also, was recognized by the American College of Cardiology last year for the extensive and exhaustive research and advancement in technology to ultimately one day wipe out heart attacks, the #1 killer among men and women globally. But was recognized by the ACC as a distinguished scientist. So the highest honor that the American College of Cardiology can bestow upon a cardiologist as a distinguished researcher in the field of cardiology, and in 1985 won the Nobel Peace Prize, and maybe we can unpack that a little bit today too. So Dr. Muller will share his insights about the hidden threats of sudden cardiac events, his research, what he thinks about the field moving forward, ideas maybe where our audience can take matters into their own hands and reduce their risk. If they are at risk, maybe some things that they can put in motion, action plans they can put in motion to reduce the risk of heart attack. So Jim, it's a pleasure to have you here, joining all of our customers out there and our people interested in education about vulnerable plaque.
Well, thank you, Jason. As you said, we've known each other for quite a while, and I had the privilege of working with you and a lot of colleagues who built that first coronary catheter that could use near-infrared signals to find the vulnerable plaques. That was an incredible venture we were on.
That was an incredible run, really set an entire field in motion. There's been hundreds and hundreds of millions of dollars and companies born and people employed and research done based on this concept that you introduced with some colleagues some time ago, back in 1989. It was probably something that you coined and talked about quite honestly prior to that. So maybe just for the audience, you can help define what is vulnerable plaque. maybe what it is and sort of how it forms, and maybe just to summarize
Yeah.
what it is.
So vulnerable plaques are hidden in the wall of a coronary artery. They're usually full of cholesterol. They have crystals. They have a little cap on them, separating them from the blood flow in the center of the artery. And what happens with almost, I would say 80% of heart attacks are caused when that cap breaks open and the blood going by is exposed to the cholesterol in the plaque and a clot forms. And once the clot forms, the coronary arteries are quite small and it blocks the artery, and then the heart muscle gets no blood, no oxygen, and begins to die within 20 minutes. So that's what causes heart attacks, vulnerable plaque rupture.
So I mentioned that photo in the background there, and I was fortunate to know you when that case occurred. It was a positive outcome for that patient there. But maybe you can, I mean, you got a clot up in the right-hand corner there.
Yes, this is
was
by chance. I didn't put this for the webinar, but there it is. So there's the clot. This is a clot that was removed. This is what the artery looked like when the patient came in. It was blocked. And then Dr. Mader took this clot out and got the blood flowing. So that's what a heart attack is. And that was fortunately a heart attack that was treated early. Within a couple hours of the onset of symptoms, you can save most of the heart muscle if you get to the hospital soon enough.
So back in the early 80s, when sort of had this idea, maybe you can explain to the group, just curious, for myself, I don't know if we ever had this conversation, but your earliest research that led to this concept of vulnerable plaque, and we'll get to where we are today, but maybe the origin story of vulnerable plaque.
It's a great question, because there is a story there. So I was working for Dr. Eugene Braunwald, one of the world's most famous cardiac scientists of the time. And he said, Jim, we're not getting patients in this trial fast enough. Why aren't you doing this? I said, Dr. Braunwald, it's this summer, and there don't seem to be as many heart attacks coming into the hospital, so we can't enroll them. And he said, prove it. So we had a database of around 800 patients. It was new to have it on a computer. This is in the late 70s. And I said to the database person, I said, show me the number of heart attacks each month of the year. I need to prove it to Braunwald that summer is a hard time. And it came back pretty flat for time of the year, although there is a slight increase in cold weather. But I said, you've got it on a computer, print it out by day of the week and by hour of the day. And to my surprise, there was a big peak of heart attacks at 9 o'clock in the morning. And I showed it to Braunwald. He said, this could be valuable. This could be a clue to mechanism. What's going on in the morning? Why would they start then? So we published it in the New England Journal of Medicine. I remember a talk show host heard about it and he said, look, 9 a.m. is bad. I'm going to stay in bed till noon and have people feed me grapes, which are also good to prevent heart attacks. So there was a lot of joking about avoiding 9 a.m. But you can't avoid 9 a.m. And it turns out it's the activation of the adrenaline in the body that starts when you get up, raises blood pressure, raises clotting. That's probably why they occur. And then we did a series of studies on triggers of heart attacks, heavy exertion, emotional stress, anger. And we published all of that. So we weren't on vulnerable plaque. We were on triggers, morning being one trigger. And then I thought, why would a tennis game trigger a heart attack one week and it didn't trigger it the week before? So I thought the plaques have to change. They must get, and then I picked the word vulnerable for a very strange reason. You asked about the Nobel Peace Prize, and as you know, that was given for work that we started with Russian doctors against nuclear weapons in both countries. And when I was doing that work in the 1980s, there were 63,000 nuclear weapons in the world. Uh, we had just, come out of the Cuban Missile Crisis in '62. There was an awareness of the nuclear threat, and there was a lot of discussion about how many nukes do you really need. And the Pentagon said, well, our nukes in North Dakota are vulnerable to a Russian attack. The Russians can take them out. So we need more. And then I would say, well, the ones on submarines are not vulnerable. So we got enough. And so I was in this vulnerable nuclear weapons discussion when we discovered these plaques. And I said, let's call them vulnerable plaques. And there have been thousands of papers now written about vulnerable coronary plaques. Most people do not know the origin of the term.
Yeah. Now that you refresh my memory, I do recall having these conversations with you, probably when we were traveling, trying to evangelize the efforts at Infuretics. But amazing story, and it really launched so many different companies, so many different careers, so many different research ideas. And I know you've consulted with a lot of companies out there about different ways to identify this both invasively and non-invasively. Maybe let's stick on the topic of having a heart attack, like the picture in your background there. I'm sure you've treated a lot of patients that have had heart attacks in the past, or maybe that were at risk of a heart attack. I had a family history, and when someone is at home and they suspect they're having a heart attack, or they're not sure, what are some things that people can do at home if they are at high risk to, and they're not sure if they're having a heart attack, to lower their risk? Or what do you do if you're just sort of not sure you're having a heart attack? You're sweating, maybe, you're fatigued, you're not having the telltale signs of chest pain, because we know a lot of ER visits are complaints of chest pain that aren't necessarily a heart attack. Most of them are not heart attacks. But if you're having the crushing telltale signs, we want you to go to the emergency room. But what do you do if you're not sure, but you're at high risk? Like, how would you guide someone who's at risk for a heart attack, but maybe they're diabetic and they're not going to experience a similar symptom to someone who is not, doesn't have small arteries? How can you take matters in your own hand when you're at home if you're at risk for a heart attack?
Yeah. So you're highlighting one of the main problems with heart attacks is that you can have, and I have treated many patients when there were coronary care units before the cath lab solved that part of that problem. But there are patients who know immediately that they're having a heart attack. And I've had more than one patient tell me it felt like an elephant standing on my chest. So that is not a problem. You know what to do there. Call 911, and they know what to do once they get to you in the hospital. Hospitals have become very good. When someone hits the emergency department with that kind of story, they'll put an ECG on, they'll see ST segment elevation, and that patient, fortunately, will be in the cath lab very soon if the patient has been taken to the right hospital, one that can open arteries. Not, it's surprising. Newton Wellesley Hospital near me in Newton here, it's a great hospital, but they don't have a cath lab to open arteries. So I would have to go to the Brigham if I needed it. And I would hope the ambulance driver knows that. Most of them do. So that's pretty simple. If you've got crushing pain or pressure, patients often don't call it pain, they'll call it pressure in their chest or in their arm. And sweating is a pretty good sign of a heart attack, that you don't unexpected sweating. But the more difficult part of the problem are the lesser symptoms. And there are heart attacks that occur without any symptoms, more frequent in diabetics. I've had patients come to me in clinic. We do a routine ECG, and we discover that sometime in the past 6 months, they've had a heart attack. And we say, did you ever have any symptoms of this? And they say, no. So these are called silent heart attacks.
Yeah.
So you've got everything in between: crushing pain, elephant, and silent, and then you have this big middle ground.
Yeah.
And of course, I've had patients in clinic who say to me, I'm having chest pain, and I can talk to them all day long and not get the right answer. What I want is an ECG. I want an electrocardiogram because, and if you gave me a choice, would you like to try to figure this out by history, or would you rather have never see the patient and have an electrocardiogram? I'll take the electrocardiogram every time. The electrocardiogram, what it's doing, it's showing heart muscle that is not getting enough blood. And it can detect that problem in the back of the heart, in the side of the heart, in the front of the heart. It can do it very well. And of course, when I'm teaching younger doctors about electrocardiograms, I always want a prior electrocardiogram. I want to see what the old one looks like, because people carry around signs that could be a heart attack that are not. There's even early repolarization. When I was working in Moscow once, the 30-year-old guard at the American embassy, they said, the general practitioner said, this military guard here has got this electrocardiogram. I looked at it, showed big ST segment elevation, but it turned out that was the same as his old ECG, and it was early repolarization. So you can solve those if you have the prior one. But I think so. Let's say a patient's home and they're having symptoms, but they're not sure what to do. That is a very difficult problem. And having an electrocardiogram.
A lot of people start to rely on their watches or other consumer-based products, thinking that a watch or a 6-lead consumer product you buy from CVS might pick up a heart attack. And so, if you're sweating or you're fatigued or you feel nauseous, you might use one, you look at your watch, am I having a heart attack? And even the Apple Watch says not used for detection of heart attack. People rely on these consumer-based products to rule in or rule out a heart attack. But you're saying, you can't do that without a 12 lead. You can't.
You'll miss heart attacks without the 12 lead. A 6 lead might find some of them, but not all of them. And the Apple Watch, as you point out, I have an Apple Watch, and it says the Apple Watch never checks for a heart attack. My guess is the FDA forced them to put that on there. The Apple Watch is quite good. It's amazingly good for heart rate, and it's also very good for atrial fibrillation. So it's got some utility, but neither of those two are going to help you with the heart attack question.
So sticking on the technology theme, you're obviously following the field. I mean, you're I think you're on your 4th company that you founded right now.
Third.
All of them dealing with events and organs like the brain and the heart, but in particular for heart attacks. And maybe early detection of some people at risk, maybe medications. What are you seeing as maybe some of the most exciting things in the prevention and maybe even in the treatment or detection and treatment? So you can go the spectrum there. If there's anything that comes to mind for prevention, detection, or treatment that you think physicians like yourself are really excited about and holding promise.
So there are several things. I guess the biggest thing that might be of interest to our listeners is the development of CT scans to find vulnerable plaques. And most people are familiar that you can get a CT scan and get a calcium score. That's pretty widely used, and it's somewhat helpful because a high calcium score can show you that there has been atherosclerosis active in the coronary artery. Unfortunately, it's not the calcified plaques that are the vulnerable plaques. That's probably the late stage. They get calcified and they're quiescent. But the CT scans have been getting not only less radiation, but better pictures. And now they're getting to the point where they can find some of these lipid pools that are in the artery. And they can say, we think you've got a vulnerable plaque. And that's a marvelous thing to be able to detect. One of the sad things for me as a cardiologist is we don't have the equivalent for heart attacks that we do for cancer of the colon. So many people have colonoscopy looking for colon cancer. But when people turn 50, 60, 70, and start getting into the age where the leading cause of death, as you said earlier, for men and women, is coronary artery disease. And you can go to a doctor and get a stress test, and that can show you that you have no blockages. But there could be vulnerable plaques that are not yet causing a blockage hidden in the wall. So if I'm going to make a little bet here, Jason. We'll meet again in 10 years, I hope, if I'm there to meet. I think in 10 years, screening for coronary vulnerable plaques will be as common as screening for colon cancer.
It's amazing to me, and I've been in this field. One of my very first jobs was selling stents and balloons for a cardiovascular company, and had the opportunity to stand shoulder to shoulder with physicians treating patients with new technologies to treat heart attacks, and the advancements in even with statins and balloons and PCSK9s have really made not very much of a dent in the number of people that are dying of cardiovascular disease. Yet it doesn't seem, at least from my perspective, that there's as much attention and money flowing into prevention and early prediction on the coronary side or the vascular side as there is on the cancer side. I don't know, first of all, do you agree with that, or
yes, I agree with it.
Why
And
is that?
Well, if you give someone the choice, you want to die at 85 of a sudden death, cardiac death, or a cancer that eats away your body, they're going to pick the sudden cardiac death. But the problem is we got a lot of sudden cardiac deaths in 50-year-olds and serious heart attacks in that age group. I think part of the trouble is that the first symptom of cardiac disease can be a disaster. So there's 300,000 sudden cardiac deaths per year in the United States. And many of those occur in people who had no known history. They might have had some risk factors that went untreated, but they don't have a history of, I had angina first. They never have a warning. It just comes, either the sudden death or the heart attack. So that's part of the problem. And that's why you get into, wouldn't it be nice if we could screen people to find out who really is at risk for a heart attack? I'll mention one more part of the screening potential. So let's say a patient does get a CT scan and the radiologist reads it and says, you have non-calcified plaque that could be vulnerable. Then you have this question. So what do I do? Well, of course, you take a statin, get your LDL below 55, and you do that. But is it possible that you could go to the cath lab, have that diagnosis confirmed with intracoronary imaging, the catheter that's right up next to the plaque inside the artery, get the confirmed diagnosis of, yes, it is a vulnerable plaque. It is a plaque that has a 20% chance of causing a heart attack in the next 3 years. Then at that moment, you have a decision to make. Do I want to leave it alone, try to treat it with meds, which are somewhat good, but not perfect? Or would I be better off with this stent? And that is as you know, the fascinating study just completed by the Koreans and Japanese, where they took hundreds of patients with such vulnerable plaques, detected in 3 or 4 different ways, which was not optimal, but they randomized those patients. Half of them got stents, half did not. And remember, this is not a stent for a blockage. This is a stent for a hidden plaque in the wall. And it turns out that the group that got the stents had better results. So now that's got everybody thinking, should we be, when a patient goes to a hospital with angina or with a heart attack, they get a coronary angiogram. The doctors will always treat the stenoses with stents, not always, usually. But then many patients would come back to me afterwards, after I'd sent them to the Catholic. They would say, look, I had a 70% blockage, they put a stent on it. I had a 40% blockage, and it's in the widowmaker artery, the LAD, proximal. It could cause a big heart attack. They didn't stent it. Should they have stented it? Maybe yes, maybe no.
Yeah.
That's where the science is right now. It's not quite clear what to do with that, but then you have this Korean study that says you should put a stent there. So what doctors are doing, if there's a nearby 70% blockage and a 40% one nearby that looks dangerous, say from spectroscopy showing cholesterol or a thin cap by OCT, they'll put in a longer stent. You're already paying the stent tax. Why not cover that thing?
Yeah, that's prevention. I was in the study was the prevent study, right? So I think you and I were both at Infraredics when we partially funded S.J. Park's study there.
Not only that, they used the catheter that you were CEO of that company, which developed and made it available. Those consoles available.
Well, it seems like stents are maybe stents are coming back full circle now. I think they were originally, the thought was to prevent, heart attacks and death, and then the research over the years has shown that there is no difference in mortality when you put a stent. Your quality of life improves. If you're having chest pain from angina or a blockage that's causing ischemia, limited oxygen flow to the heart muscle, that you'll have a better quality of life, but they don't necessarily impact mortality or your heart attack risk. But this data is super promising because stents have gotten so good and they heal so rapidly. They're not without risk, they're not with zero risk, but ultimately maybe stents will come back around to prevent heart attacks. That'd be very exciting.
Stents, or there's one other interesting option I know you know about, is drug-coated balloons, because when we first started doing balloons in the artery, you could get rid of the narrowing, but then it would come back. So then they coated it with a drug to prevent restenosis. And those balloons are around. They're used a lot in the legs. And it could be that those drug-coated balloons are the best treatment for a vulnerable plaque because they don't leave metal behind. If you trade a vulnerable plaque for a stent, you're stuck with a 1% risk of stent clotting forever. So that gives the balloon a bit of an advantage. And of course, if there's no stenosis, you may not need the structural support of a wire cage to keep the artery open.
Yeah, very, very exciting. So maybe the future is a CT scan finding these vulnerable plaques, low Hounsfield units, and then you go into the cath lab and evaluate with OCT and near infrared spectroscopy in the cath lab. And if you have one of these vulnerable plaques in an area that could cause a major heart attack, that could be the coup de grace at prevention. Got to get insurance companies to pay for that.
Dr. Badaleri, I like your advice so much. Are you taking new patients?
So let's say thank you. I've learned I learned from one of the best. Um, so if let's say you have been diagnosed with heart disease, you do get a CAT scan. Right now, there's not many physicians in the US that will put a stent if it's not causing myocardial ischemia or blocking flow by fractional flow reserve measurements. What do you do as a patient then if you are at risk for a heart attack? Is it just get your LDL below 55? Is that what what do you do? What do you tell your patients?
So, well, first of all, for 3 years now, I've been retired from patient care. So I I get this option to talk to patients now in this way, which is fun. But I don't daily treat patients. But I do research. I'm doing science on this. But what the science and what I write about, of course, is get the there's a surprising number of patients once they're known to have coronary disease don't get their LDL down to 55. And it's a shame. It may be over half of the patients are not treated to goal. And you mentioned PCSK9 inhibitors. You can take a shot once a month or once every 2 weeks that can bring the LDL down, but you can't get those paid for unless you failed statins. Statins are still the first line. It usually takes failing two different statins before the insurance company will pay for the PCSK9 inhibitor. And then there are some new things where you get a shot once every 6 months, and it can lower your LDL quite well, inclisiran. So the cardiologist has some marvelous tools to get the LDL low. And that is by far the biggest thing to do. I mean, we all know it's best to stop smoking. Smoking makes the blood more likely to clot. And that is obviously the best thing to do. And weight loss is always good. Activity is good. And control of high blood pressure. Those high pressures can lead to more atherosclerosis. So those are the old standbys, and they work pretty well. I mean, patients that have had an event and are under the care of maybe a cardiologist at first, and then their internist or primary care, their outlook can be as good as the general population when they get on the right meds. Now, unfortunately, the general population also is at risk for heart attacks. So it doesn't mean that everything is settled. I think for patients there who are questioning what to do about plaques, if you're lucky enough to be in a hospital that has and I have no conflict of interest here, infrared X device, which has near infrared spectroscopy, which you used in chemistry lab to find the chemistry of the plaque, then you really know what kind of plaques you've got. And that can be an added incentive to get the LDL low, or maybe even lower than 55.
Yeah. So if you need a cath, maybe you do some research and find out where they have a spectroscopy catheter to look at the chemical composition of your plaque. While they're in there, it'd be nice to be in a place that has that type of technology.
Yeah.
Let me ask you a question, Jim, because we've reconnected recently about your new endeavor, and I want to give you an opportunity to answer a couple of questions there, because I think what you're doing is incredibly exciting, and I know how challenging it is to get funding for projects, but your new idea that you've launched is this application for stroke detection, and granted, it has to go through clinical trials and cost benefits, but maybe just a word or two about ECAS and what you're doing there at ECAS for stroke detection with an application.
Yeah. So this is the third company. The first was with you on near infrared. Second, combined OCT with near infrared. That company, SpectraWave, is flourishing. And then the third company is Emergency Call for Heart Attack and Stroke. And a neurologist came to me. He said, Jim, you've done a couple of companies. He said, stroke patients sit home they don't come in. If they came in, I don't know if you can see it up here. So this is the heart attack one. This is a stroke up higher. And so we're trying to work against both heart attack and stroke with an app that will help patients to know when to call 911. So this is the app, and it's got these questions in it it's the same questions I would ask a patient in the emergency department, trying to decide if they've got a stroke, a heart attack. Of course, I would want an ECG. That's really what I want. And if they had a home ECG, it would be massively helpful for them. But the real fun with this app is when it comes to the stroke side. The app does a finger tapping test, which is what a neurologist does in the emergency department for a possible stroke patient. And then it analyzes the face, looking for asymmetry, and it analyzes the voice, all compared to baseline when the patient enrolls. So this has been a very fun company. We've raised about $3 million for, you mentioned the catheter companies. They took over $100 million each. This one, we've raised $3 million from angels, including Ken, whom you know well, Jason. But we've been rejected by 42 venture capitalists who said that we don't want to fund you until the FDA approves the device. So now we're running out of money. That's kind of the life of a startup. 9 out of 10 startups fail. So we're struggling, but we are writing grants to the NIH and to ARPA-H because they're a little more, those organizations are not afraid of FDA risk, whereas the venture investors are.
It's amazing. I mean, it's incredible. Hopefully, it can get off the ground because it's another endeavor by you to try to help humanity and save lives, and it's admirable and exciting. And I hope the funding comes through. We're coming up on time. I do have some questions from the audience. If I can throw a few of these out. Some of these are sort of personal questions, but I won't. Maybe you could do a telehealth visit with some of these participants. So I'm going to start at the bottom here. I think that's the order that they came in. So what are your let me start here by asking this question. I had a CT score, but would like to avoid statins, and I've already changed with diet and exercise. So what else can I do if I don't want to take statins?
It depends on the LDL level. If the LDL is 70 and you don't want to take statins, that's probably a good choice. If the LDL is 130 or 140, then the risk is so high that the statins are probably indicated. I've certainly had patients with those questions, and I would probably come back with a question. Why don't you want to take statins? Is it you're worried about side effects? And the good thing about the side effects of statins is that they are reversible. So if you take a statin and you get muscle pain in the legs, which people get, maybe 10%, and you stop the statin, the pain goes away. And also, you can have side effects to one statin, but not to another. So that would be my answer.
Good. Yeah, I was at a 4th of July barbecue, and a very good friend of mine was just diagnosed with high cholesterol about 6 months ago. Thought it was dietary induced, cut out dairy and meat, and had basically little to no effect, and didn't want to take a statin. I said, there's way more benefits to a statin than there are downsides. Like there's plenty of studies showing reduction in inflammation, and I think there was a benefit from colon cancer. I mean, obviously it's not the main indication for the drug, but if you can tolerate it, a lot more benefits to it than downsides. Jim, we have a guest who asked for people that maybe are at risk of having a heart attack, or they've had a, or they, have a family history of heart attack, how many of those first heart attacks or people who are at risk, how many present as sudden death? Are there stats out there? Say your
Yeah,
first heart attack, yeah.
yeah, that's a tough question to answer. I don't know of studies that have broken that down like that. But I will say that, I've had many patients that come to me and they're very worried because they have a family history of heart attacks. And in many cases, those earlier heart attacks occurred in people that smoked. So if you have a grandparent that smoked and had a heart attack and you don't smoke, you're not carrying with you that risk factor. So that's a good thing. Alternatively, high cholesterols can run in families. So the most important thing is to find what is the LDL bad cholesterol. We haven't mentioned inflammation.
Yeah.
There is a giant school of thought that increased inflammatory processes are connected to heart attacks. There's something called C-reactive protein that if that's elevated, that can also increase your risk. And there are some evidence that colchicine, which is an anti-inflammatory agent, can be helpful. So, if people don't want to do statins, they might consider colchicine. It's a good thing to ask your doctor about.
Yeah, for sure. Inflammation, for no matter what ails you, is not good. And I know there's a lot of research on inflammation identification and treatment. So we have another person here who said, I'm fresh off a STEMI. I have sleep apnea. Been treating my sleep apnea with a CPAP for 10 years. And wondering if sleep apnea is a big factor in relation to heart attack and coronary artery disease. And if so, why aren't people talking about it more?
Well, sleep apnea can lead to lack of oxygen. And then if you have lack of oxygen in your blood going to the myocardium, that can cause trouble. So it's not surprising that sleep apnea and coronary disease are associated. They often can occur with obesity, where the two of them are there together, which of course there are treatments for that now, fortunately, and that can be something to deal with. But I think the reason people are not talking about sleep apnea and coronary disease a lot is because while there is some association, it's not that strong. The association of heart attack with high LDL cholesterol is much stronger.
Got it. What some of these are personal questions. We have a lot of questions, and there's no way I'm going to be able to get to them all. Over, I think there's 49 questions here. I'm going to try to let me ask you this question, because we are going to be doing a webinar on INOCA and MINOCA coming up. Ischemia with non-obstructive coronary disease and myocardial infarction and non-obstructive coronary artery disease. Any thoughts on that? And generally, treatment, diagnosis, living with MINOCA, INOCA.
Yeah. So both MINOCA and INOCA, I think I'm going to make a guess, in about half the cases, if the patient had been studied with a spectroscopy catheter, they would find a plaque in the wall that did not show up on an angiogram because it's not showing a narrowing, not causing a narrowing, but it's part of the wall that is diseased. And that cholesterol hidden in the wall in that spot can cause spasm. So you can end up with events that occur due to spasm, and they're related to coronary. The doctors often say no coronary artery disease. What they mean is no stenosis. But the truth is there can be disease in that wall that doesn't show up as a stenosis. So And of course, the treatment for that would be the same story, lower the LDL.
Boy, we're coming up on time here. I got so many questions. I'm trying to get to ones that are more general questions, maybe to help the
So Jason, while you're looking through those questions, I want to directly comment to how many people are listening to us?
We have over 250 here. We have 1,300 that are registered and waiting for the recording.
Well, I want to thank people for their interest in this, and I think it is something that I enjoy doing and want to do, is to get some of this knowledge a little more in circulation. And I'd be happy to do it again, if we don't get through all these questions this time.
I think that would be a good idea. We can look at some of these questions and maybe see the commonalities and common themes, because there are some commonalities here. What do you do if you can't tolerate a statin? And what can I do to revert? Can I reverse cardiac plaque if I've already been diagnosed with it?
Yes. So I like both of those questions. Okay. So if you can't tolerate a statin, Repatha, PCSK9 inhibitor, is just great. But you have to prove it to the insurance company that you can't tolerate it. So that's where
can you reverse a coronary plaque if they found one on CT scan or a cath?
So there are Japanese studies where they found, I don't know if you saw, I think you saw this one, Jason, where they found a coronary plaque in the left main coronary artery of a 55-year-old man by near infrared. And as you know, the Japanese image arteries much more than the American doctors are, because the imaging is paid for. And it's part of the Japanese approach to be thorough, very thorough with this. So they found this giant yellow spot, cholesterol rich, in the left main coronary artery. And this person changed his diet, took statins, exercised, and they repeated the study, and the yellow spot was gone, probably because he had put on a layer of tissue over that plaque and passivated it, kind of made it more dormant. So I think that's a good example of the device you helped build probably saved his life, because he saw this thing and he knew, even though it wasn't causing a narrowing, he knew he had this. And the general answer to the questioner is yes, if you've got a vulnerable plaque, you have a chance of reversing it with meds. It's not 100% effective. And I do worry about this, that while keeping the cholesterol low can prevent you from developing these vulnerable plaques, it may be that once they get going with a lot of inflammation, neutrophils in there, collagenase, it may be that once they get going, they actually need focal treatment with a stent or a balloon plus good meds.
Well, I hate to cut this short. We did only allocate 45 minutes, and I do think it would make a lot of sense to do this again with you, and maybe even narrow in or expand the topic. We're going to try to do our best to print off the questions and get to them, and maybe circulate the responses to the attendees here today. But in summary, vulnerable plaque are plaques that materialize. They're lipid rich in the coronaries. They have a cap over them that are thin, that makes them vulnerable to rupture into the bloodstream, causing a clot that reduces blood flow to the myocardium, the heart muscle, that ultimately causes a heart attack. It's the cause of probably north of 80% of all heart attacks is a vulnerable plaque that ruptures into the bloodstream. And if you're at risk, or you've been diagnosed with high cholesterol, getting your cholesterol as low as you possibly can, stopping smoking, or losing some weight, exercising, are common themes on these webinars. Certainly not new, getting your hypertension under control. But I want to leave maybe an opportunity for you to give some parting thoughts to the audience here. I don't mean to steal your thunder there. Those are the takeaways that I got and that I've gotten from you over the years, but any parting thoughts you can give to the audience here on maybe.
I thought that was such a good summary. I can't improve on it.
Well, it's a pleasure to have you here, Jim. You know, you are such a remarkable human being, also an incredible golfer. I actually had the opportunity to play with Jim when he had I believe you had your hip was hurt, so you had to play lefty one day. So you could hit the ball farther with your left-handed club. I think you were actually using maybe a right-handed club that's swinging at lefty. I don't know how you were doing that.
It was a left-handed club. It was a left-handed.
You're a musician, you know, advocated for the world to reduce the proliferation of nuclear weapons, founded a really important field, the cause of 80% of all heart attacks, and continue to set the standard for, you know, helping humanity. And I can't thank you enough for joining us today, and we'll definitely do it again.
So maybe we even play golf again, Jason.
I'd love to.
Let's do it.
Okay. Bye, everybody. Thank you so much for joining us, and we'll see you next month on the next webinar. Appreciate all your attendance today. Take care. I'm Jim.
Bye-bye.